vamos receber para conversar conosco a respeito de gamopatia monoclonal de significado neurológico o Dr. Michael Rosenzweig. É oncohematologista e coordenador da divisão de mieloma múltiplo e professor associado do Departamento de Hematologia e Transplante de Células-tronco hematopoéticas do Hospital City of Hope. E aí, só para conveniência e maior conforto do nosso convidado, eu vou mudar a língua, vou convidar o Dr. Michael em inglês. So, please welcome Dr. Michael Rosenzweig. Welcome, and it's very nice to have you here with us again. Please.
Thank you so much for having me, and thanks for coming to hear about monoclonal gammopathy of neurologic significance. It's always a pleasure to come here and visit. Hopefully, one day I'll be able to come and give this presentation in Portuguese, but not today. So let's get started to talk about monoclonal gammopathy of neurologic significance. So I started here with the spectrum of monoclonal gammopathies. And as we can see here, and as we know, the monoclonal gammopathies are a spectrum of diseases. Of course, starting with let's see how this works. With monoclonal gammopathy of undetermined significance on the far left side of the spectrum and the most benign part of the spectrum, where we have a very low plasma cell burden of less than 10% in the bone marrow and less than 3 grams per deciliter in the peripheral blood monoclonal protein. And of course, no myeloma defining events, which I define here in the lower right corner as those classic Crab criteria of hypercalcemia, renal insufficiency, anemia, and bone disease. And if there's a higher plasma cell burden, we move over to smoldering multiple myeloma, where we have at least 10%, but less than 60% plasma cells in the bone marrow, and a higher monoclonal protein in the blood or the urine. But again, no myeloma-defining events. And of course, active multiple myeloma, where there are either myeloma-defining events of the classic Crab criteria, or the biomarkers of disease that make up what we recently called in 2014 the slim Crab criteria, where patients can have at least a bone marrow biopsy of at least 60% plasma cells, free light chain ratio of at least 100, and at least one or more lesions by MRI greater than 1 centimeter. It's a little bit controversial, those slim Crab criteria, but those are the defining events that we're using to define multiple myeloma for which we offer patients treatment. We don't typically treat, of course, MGUS or smoldering multiple myeloma, except in the high-risk setting, and we can talk about that later. But what I want to highlight is it's sort of in between in the course of a patient with MGUS or smoldering multiple myeloma. There are other conditions that we need to be aware of that could appear. Patients with a solitary plasmacytoma may have elevated monoclonal proteins and not meeting criteria for either smoldering myeloma or active myeloma. And of course, patients who have clinical symptoms, we need to be aware of diagnoses like AL amyloidosis or POEM syndrome. And also what we'll talk about today is the monoclonal gammopathies of clinical significance, including neurologic significance. So when we have a monoclonal gammopathy of undetermined significance with a low plasma cell burden and no myeloma-defining events or smoldering multiple myeloma, we really need to be careful. Is this really no significance? We want to be very careful and do a very careful history and physical exam of our patients to assure that there really is no significance if we're going to make that diagnosis. Is there weakness or fatigue? Is there volume overload? Is there orthostasis or lightheadedness upon standing, anorexia, early satiety, sensory changes, sexual dysfunction, GI bleeding, weight loss, symptoms of malabsorption, nausea or vomiting? Sorry, excuse the formatting. I guess it kind of got a little changed up with the jump drive. As joint pain or immobility or skin changes. In fact, for AL amyloidosis, the most common presenting symptom is fatigue. And as you know here, these are all very non-specific symptoms. And it could be due to patients with with a monoclonal gammopathy and due to other causes, but we want to be very careful and make sure the monoclonal gammopathy is not related to these symptoms, therefore making the diagnosis of monoclonal gammopathy of clinical significance rather than of undetermined significance. So when we talk about a monoclonal gammopathy of clinical significance, it often involves a quiescent or often small B-cell clone. The symptoms may be related to the monoclonal immunoglobulin or the clone itself, or by some other mechanism other than the tumor burden. That's really what we're talking about here, is when the tumor burden is not directly related to the disease, but maybe indirectly related to disease. And this is from Dr. Despensieri's definition that she presented in the ASH education book. It's really divided when we talk about monoclonal gammopathy of clinical significance into organ systems. The renal system, where it could be a monoclonal gammopathy of renal significance. In the absence of cast nephropathy, which is what we would see with multiple myeloma, dermatologic significance, where there may be skin lesions, which we won't talk about too much today, and of course, nervous system, or monoclonal gammopathy of neurologic significance, which we'll elaborate on more here. So what is the neurologic system? We worry about mostly involvement of the sensory, peripheral, or autonomic nervous system. We don't really think about the central nervous system so much for these diseases. Sensory damage, very nonspecific symptoms, as we all know, and can be very difficult to pinpoint. Numbness and tingling, burning sensation, balance issues. Some nonspecific balance issues can often be due to peripheral neuropathy. Muscle pain or cramping, even nonspecific things like sweating or heat intolerance. Early satiety, like we talked about, as a result of the autonomic nervous system, sexual dysfunction of impotence, reflex abnormalities. These are really the symptoms that we're looking for. So let's talk more about the monoclonal gammopathy of neurologic significance and key features. First of all, we need to have a monoclonal gammopathy, and it's more common IgM than IgA or IgG, but we'll talk about those diseases that include an IgG or IgA. This is really a diagnosis of exclusion. We want to be very careful that other causes or other illnesses and conditions are not contributing to neuropathy. And these are the classic ones here: diabetes, cobalamin deficiency or other vitamin deficiency, prolonged alcohol or drug use, HIV or hepatitis infection, and autoimmune conditions. One of the biggest challenges is this is often a clinical diagnosis that's based on our own clinical assessment, some laboratory skills, rather than a pathologic diagnosis, which is, of course, what we're more accustomed to as oncologists. We want the tissue to make the proof. But nerve biopsies are often difficult to obtain, and they can have a high degree of morbidity and associated with permanent sensory or motor loss. So we want to be very careful and do those nerve biopsies really only as a last resort. So the monoclonal gammopathy of neurologic significance is really a clinical syndrome. And this DADS-M, which is the distal acquired demyelinating systemic neuropathy with monoclonal gammopathy, is what the clinical syndrome is that we're talking about. Most commonly with an IgM disease, it's often symmetric, involving both hands and feet. It's length dependent, similar to that in diabetes, where the long nerves are impacted first, and very slowly progressive, and again, a diagnosis of exclusion. These can be a paraprotein neuropathy, where patients may have a defined neurologic and hematologic condition with peripheral neuropathy, or they can be in the absence of a defined hematologic condition. So there becomes a bit of an overlap when we talk about these diseases. But some of the true paraprotein neuropathies are things that we are familiar with. Systemic light chain amyloidosis is a true systemic hematologic disease with associated neuropathy and really doesn't fall into the category of monoclonal gammopathy of neurologic significance. Of course, patients can have neurologic symptoms with multiple myeloma itself, or even a solitary plasmacytoma may have neuropathy implications. Waldenstrom's, a known hematologic disease of IgM monoclonal restriction, often presents with a peripheral neuropathy. In a POEMS, which we'll talk about more, Castleman's disease, an autoimmune inflammatory disease process, can have can have neuropathies. And then this syndrome of Canomad is a kind of a unique syndrome where patients can have chronic ataxic neuropathy, vision issues with ophthalmosplegia, the presence of a monoclonal gammopathy, cold agglutinin disease, and these monoclonal antibodies. This is a important diagnosis to make. So when we evaluate someone with a monoclonal gammopathy of neurologic significance, here's a comprehensive list of tests that we would order. And I kind of highlighted the most important ones here in red. Of course, the metabolic panel and blood count are very important to look for any other clinical significance and electrolyte abnormalities. We want to do a full evaluation for a monoclonal gammopathy with a serum protein electrophoresis, serum free light chains. If an IgM is present, an anti-MAG antibody level is very critical to check, and we'll talk about that. The VEGF level can be very helpful. A PET scan is a go-to exam that we use to look for localized disease or skeletal involvement or anywhere the disease may be impacted, and can really impact our management that we'll talk about, particularly in POEMS. A fat pad biopsy, critically important in making the diagnosis of AL amyloidosis. And nerve conduction studies. I'm not a neurologist, I'm not an expert in reading these tests, but this is really very, very helpful for the neurologist in delineating the type of disease that may be present in a patient with peripheral neuropathy and a monoclonal gammopathy. And I should say that in all of these diseases that we've talked about, including POEMS, AL amyloidosis, or any monoclonal gammopathy with neurologic significance, it's really important for us to have good partnership with our neurology colleagues to take care of these patients. So let's talk more about if we start with a monoclonal gammopathy and peripheral neuropathy. So the first thing that we like to do is a nerve conduction test. And this can be very helpful in delineating whether this neuropathy is a demyelinating peripheral neuropathy or an axonal peripheral neuropathy. This is very, very helpful for the neurologist in differentiating the type of disease that may be present. Again, not an expert in reading these tests, but just to give some classic symptoms, the demyelinating peripheral neuropathy on EMG and nerve conduction testing will have slow motor conduction, prolonged distal latencies, a low terminal latency, and reduced or absent sensory responses, which the neurologist can help us interpret. Axonal neuropathies present a little bit differently on the nerve conduction studies, including a reduced amplitude of the action potential, or the so-called SNAP, reduced compound muscle action potential, and distal latency and conduction velocity, which remain near normal compared to a peripheral demyelinating neuropathy. So if we fall into the category on this left side of the demyelinating peripheral neuropathy, we want to look and see what type of monoclonal protein we have. And let's start here with the IgM disease. If patients have an IgM monoclonal gammopathy, that can really be very, very helpful in us making a diagnosis. So we want to check first if patients have an IgM for that anti-MAG antibody to see whether that's present. This is the anti-myelin antibody that is most commonly seen with IgM disease. So let's start there with anti-myelin associated glycoprotein or anti-myelin associated anti-MAG antibody peripheral neuropathy. This is the most common type of IgM paraprotein neuropathy. It's associated with a clonal IgM production. It can be an IgM production in the setting of an IgM MGUS, where there's no other clinical disease or the paraprotein neuropathy, or in the setting of a known disease like Waldenstrom's macroglobulinemia we talked about, may have an anti-MAG antibody, even marginal zone lymphoma, or CLL can present with a concomitant anti-MAG antibody. Again, this DADS-M, the length-dependent, slowly progressive sensory neuropathy with a monoclonal gammopathy is often present with anti-MAG associated peripheral neuropathy. While classically demyelinating, the motor and axonal features can actually occur late in the disease. And you'll often see patients who go undiagnosed for a long period of time may start off with a sensory neuropathy, and because it's associated incorrectly with another illness and physicians fail to pick up the monoclonal gammopathy, it may progress to involve axonal features and even motor features late in its disease progress. So what we want to do is we want to test for the anti-MAG antibody. And here's just some examples of what the high titers are greater than 70,000. Those are the ones that are considered clinically significant. But it's important to know that if patients have a high titer of IgM, the disease process is not associated with the anti-MAG level. Any level that's clinically significant needs to be considered because, like I said, the level of the titer has no impact on severity. We want to make sure that we treat the underlying disease process if present. If patients are diagnosed with Waldenstrom's lymphoma or CLL, we want to go ahead and treat that. In the absence of treating those diseases directly, here are some treatments that we can use specifically for anti-MAG antibody peripheral neuropathy alone. Rituximab, very helpful. We may use this in combination with other agents like cyclophosphamide, fludarabine, or bendamustine. But to be clear, the data on treatment of anti-MAG antibody is a bit controversial and sometimes contradicting and quite limited. I'm going to go over one of the studies. But the real-life prospective studies, or retrospective studies rather, do show a benefit of rituximab in treating these diseases, and that is something that I have incorporated into my own practice. And obinutuzumab can be a helpful treatment for anti-MAG antibody-associated neuropathy. So this is one trial that I wanted to highlight here today. This is a placebo-controlled trial that I thought was very useful in treatment of IgM-associated peripheral neuropathy. It included 26 patients with an anti-MAG antibody and peripheral neuropathy, and they just got rituximab for 4 weekly doses, and compared that to placebo. And you can see here where the red line represents those receiving the placebo and the blue receiving rituximab, that there has been a drop in the IgM levels with rituximab, not surprising. Likewise, a drop in the anti-MAG levels with rituximab. What's encouraging here is they did some neurologic testing scores. This is the INCAT, which again, this is something that our neurology colleagues can help us with. The inflammatory neuropathy course and treatment score, and you can see that those scores went down, which is an improvement in those getting rituximab compared to those getting placebo. And then this is the difference in the 10-meter walk time, and that there was a drop in the time that it takes to walk 10 meters in those receiving rituximab over time, over a period of months, compared to placebo. So this is one study that shows a benefit. I think it's a useful study, is a placebo-controlled study. But to be clear, in the interest of time, I'm not going to show all the studies, but there are contradicting studies that have not shown a benefit. And like I said, while the data is controversial, it is something that I've worked into my own practice and tend to use rituximab for these patients. Of course, Waldenstrom's, very common cause of an IgM monoclonal gammopathy and peripheral neuropathy. I won't go into the details of Waldenstrom's for this lecture, obviously characterized by the proliferation of mature lymphoplasmacytic cells rather than a plasma cell population. So a bone marrow biopsy is very important to differentiate the two. It's associated with IgM most commonly, rarely IgA or IgG, although I have seen a lymphoplasmacytic disease with an IgA rather than IgM. The MID88 is a very useful test to run on genetics. It's found in nearly all patients with Waldenstrom's. We also want to look for the CXCR4 mutation in our Waldenstrom's patients because this can be very useful in determining prognosis and guiding our treatment with the BTK inhibitors. We often are using BTK inhibitors for Waldenstrom's, ibrutinib or acalabrutinib most commonly, and those with a CXCR4 mutation tend to respond less favorably. Peripheral neuropathy is relatively common in Waldenstrom's, in the presence or even absence of the anti-MAG antibody occurring in more than 60% of patients. And again, most commonly demyelinating, but in advanced disease that gets left undiagnosed, we can see axonal disease later. Now, if the anti-MAG antibody is negative, as seen here, this is an important test to get. The anti-ganglioside antibody can be very useful in eliminating other diseases, because the Canamad diagnosis is a disease that may present with positive anti-ganglioside antibodies. Not a workup I do very often as a hematologist. Again, a good reason to have neurologic partners. Again, this Canamad diagnosis with the chronic ataxic neuropathy, ophthalmoplegia, IgM protein cold agglutinins, and the anti-ganglioside antibodies that I've highlighted here. Patients can present with ataxia, areflexia, difficulty walking. Patients may have difficulty swallowing or speaking. And you can imagine if this is left untreated, the progressive nature can be quite debilitating and devastating. So IVIG is a very useful treatment for this disease. We use it in the same way we would treat anti-MAG antibody. So back to our algorithm here. If the Canamad is negative, if the anti-ganglioside antibody is negative, then we want to consider these other diagnoses featured here, CIDP, or even just the DAD syndrome in the setting of a monoclonal gammopathy. CIDP is an important diagnosis for us all to be aware of, and I think it's important to remember that many patients will come to us come to us as hematologists, at least it's true in my own practice, with a diagnosis of CIDP that fails to respond to treatment. So many of these diseases, the CIDP is the first diagnosis made and can at times be a misdiagnosis. So again, we talked about this DAD syndrome, which occurs in the setting of a monoclonal gammopathy. This is truly the diagnosis of exclusion. And again, presence of an IgM monoclonal gammopathy and that peripheral neuropathy. The sensory ataxia is the most common sign, and we want to treat this with rituximab or IVIG. Now, the CIDP is an important diagnosis for us to go over. This is the acquired chronic neuropathy with demyelination that can be relapsing, remitting, or even progressive. And these are the diagnostic criteria that I've featured here. It's progressive over at least a couple months. Weakness is more common than just sensory symptoms. The proximal muscles may be involved along with distal muscles. We can have widespread reduction, loss of deep tendon reflexes, increased CSF protein if an LP is performed, and the nerve conduction studies show evidence again of the demyelinating neuropathy rather than the axonal neuropathy. If we do a biopsy, we'll see segmental demyelination rather than inflammation, and the gait ataxia is a common symptom of this disease. So again, this also requires a diagnosis of exclusion because other diseases can present similarly. Lyme disease, toxin or exposure, the anti-MAG antibody that we already talked about, even POEM syndrome, we want to be very careful to exclude before making this diagnosis. Peripheral nervous system lymphoma, a rare manifestation of lymphoma, and of course amyloidosis, we want to exclude before making the diagnosis of CIDP. If all those diseases have been excluded, and again, the algorithm takes us down that pathway where the anti-MAG antibody is negative, the anti-ganglioside antibody is negative, and we wind up with a diagnosis of CIDP, the goal is to stop that immune attack that's occurring against the myelin sheath. IVIG is the preferred way to start. We usually do 2 grams per kilogram as an initial dose given over 4 to 5 days, and then continue with 1 gram per kilogram, can be divided over 2 days every 3 weeks. The majority of patients will respond within 9 weeks of treatment. And so again, as I was talking about, failure to respond after 9 weeks should raise red flags for us and realize that perhaps one of those diagnoses of exclusion were not made appropriately, and another diagnosis is present that needs to be treated, like POEMS or AL amyloidosis. Plasma exchange can be useful in severe cases. I'm not doing that routinely in my own practice, and steroids can be useful as well in the setting of failure to IVIG. So let's go back to our algorithm here, and if we make a diagnosis with our nerve conduction test of a demyelinating peripheral neuropathy, and rather than an IgM, we see an IgG or IgA disease, this should start us thinking about POEMS. POEMS is a very important disease that is often missed. Patients will often progress to have very severe neuropathy during the interim time that they're misdiagnosed with another disease, commonly CIDP, but very gratifying to treat as a hematologist. I have a number of patients who have done quite well with treatment for POEMS, and they respond incredibly nicely to our anti-plasma cell agents. So I want to take a few minutes to talk about POEMS here, even though it's not really a monoclonal gammopathy of neurologic significance, but a disease entity unto itself. So POEMS syndrome, an acronym, stands for polyneuropathy or polyradiculopathy, the O for organomegaly, E for endocrinopathy, M for monoclonal gammopathy, and S for skin changes. This is a clinical diagnosis that I'll talk about. All criteria do not need to be present. The acronym has been first suggested, it's pretty recent, as early as the 1980s, but cases of this disease have been reported going back into the 30s. So this is the criteria, an important table to keep readily available to make the diagnosis. First and foremost, the two mandatory criteria are the polyneuropathy and the monoclonal gammopathy. So patients absolutely have to have those two features to make the diagnosis. The other major criteria, of which you only need one, is a presence of Castleman's disease, which is usually made following a biopsy of a lymph node, sclerotic bone lesions, or an elevation of the VEGF. I like to just kind of highlight that checking a VEGF and seeing that it's normal is not sufficient to eliminate POEMS disease. I think that's a common misperception, that the VEGF does not have to be elevated to make the diagnosis of POEMS disease if at least one of these other two major criteria are present. And then we have the minor criteria, of which only one needs to be present: organomegaly, which we may see in our imaging tests, the extravascular overload, often presenting with peripheral edema, endocrinopathy with an abnormal hormonal function, skin changes, eye abnormalities, papilledema, so we want to include our ophthalmology colleagues. And then the thrombocytosis or polycythemia is another minor criteria. I also listed here some of the other non-specific features that one can see in POEMS. So this is just a quick image of the skin findings that we may see in POEMS, very non-specific. Hyperpigmentation, as seen in this upper left corner of the images, increased hair growth with hypertrichosis, atypical hemangiomas. This is another example of hemangiomas that are darkened, these white nails, acrocyanosis, and dry skin. So non-specific skin changes may be related to POEMS syndrome. I personally involve my dermatologists in making this diagnosis as well. The skeletal changes that we may see are often sclerotic rather than lytic that we may see on with myeloma or another plasma cell disease. And these is just some images of the sclerotic changes. The VEGF. This is a very important test. Again, not required for the diagnosis. It's related to cytokine. It is a cytokine that's overexpressed by osteoblast macrophages and plasma cells. It increases the vascular permeability and is a major criteria for POEMS, but again, not required. We can measure it in the serum or the plasma. It's important to know which way your lab does it, because the parameters for normal limits is off. There can be higher levels in the serum rather than the plasma, and this is due to platelets that can release VEGF. So just important to know what your lab is doing. When we make the diagnosis of POEMS, we want to be careful in being thoughtful and mindful of our treatments, and I featured the algorithm here. The most important thing to determine in POEMS is it a systemic disease or is it more localized? Because one can have a localized area of POEMS that we may be able to avoid systemic treatment. So what we do is we start with a bone marrow biopsy, and if there's lymphoplasmacytic cells on the bone marrow, in the bone marrow biopsy, then that's clearly systemic disease, and we want to use systemic therapy, which we can talk about in the next slide. If the bone marrow is negative, a PET scan can be very, very useful in looking for whether this is widespread disease or localized disease. So if there's less than 3 lesions on the PET scan, we may be able to cure these patients with radiation alone to the localized lesion. But of course, if there's more than 3 lesions, then that really gets you into the systemic category, and we want to treat that with systemic treatment.